All right, everyone, I think we're going to get started. Want to welcome everybody for joining us this evening for the A4M Webinar Wednesday. Our topic tonight is the State of Women's Health 2023. I think it's fitting as we just finished January, our first month of 2023. And we're all getting ready for some women's health courses that are coming up here at A4M. So we're super excited to have Dr. Erica Schwartz with us this evening. She's also part of our A4M faculty in our hormone-related courses, in our peptide courses, also the host of Redefining Medicine, the A4M podcast as well. Dr. Schwartz is a leading expert in prevention, bioidentical hormone therapy, peptides, and longevity medicine. She's the founder and CEO of Evolve Science and the Better Health Initiative. And she's committed to education. If you've been around as long as I've been, Dr. Schwartz has been, she's definitely been a pioneer in women's health and hormone replacement therapy, and kind of an advocate in fighting that fight for many, many years to bring evolved healthcare for women. Dr. Erica is also the author of 8 best-selling books. She's been a TEDx speaker, and she sees patients in New York City from all around the globe. So welcome tonight, Dr. Schwartz.
Oh, Amy, thank you so much. And thank you to A4M. I'm so grateful for the opportunity. To speak about this topic is just unbelievable. That to talk about women's health in 2023 is an amazing opportunity, because not only am I a physician and I've spent the past 40 years of my life listening to women speaking all day long, literally, whether they're 5 a day or 20 a day, about issues that are all about health at the end of the day. But I'm also a mother, a grandmother, a daughter. And this is what I've devoted my whole life to, which is women's health. And I think that, after all these years, it's time to come clean. It's time to tell the truth. And it's time to see where we came from, where we are, and where we're going. It's time for all of us to come together and change the healthcare system to improve women's health. So I have no words to tell you how happy I am. I'll get it together soon enough. So I figured I'd start with the report cards, right? I mean, we all go to school, we all learn, we all know about report cards. So I thought that if you look at women's health today, in prevention, I'd give it an F. In mental health, I'll give it an F. In postpartum, I'll give it an F too. In reproductive health, just an F too. And female aging, needless to say, you know what I'm going to say, F. Now, I don't want you to think that this talk is going to be a downer. It's going to actually show us how we got here. And I'm going to come up with solutions that my patients have taught me, that reading has taught me, that my colleagues have taught me, and it's time to actually implement it. So we knew that how bad things were for women from 1992. I mean, if you think about it, that's 31 years ago. Gender bias documented for social science exists in all pervasive in medical research. Now, this was 1992. There was actually a journal called Women in Therapy, and I don't even know where it came from or where it is, but clearly it doesn't exist anymore. They knew that there was gender bias, which reminds me of a story that in the early 80s, I was doing a lot of TV, and I got invited to give a talk on CBS Evening News to be interviewed about women's health and about how women, really there was gender bias because women were not being used in experimenting for pharmaceuticals. So what did I think about it? And I remember sitting in the CBS studio and being interviewed by a lovely woman reporter who said, well, what do you think about that? And I said, and here I was in my 30s at the time, and I was like, I never thought about that. I didn't even know as a physician, and I was already a practicing physician. I was running a trauma center. As a physician, I had no idea that research on new drugs did not involve women. Pretty good, huh? Really impressive. And then let's move fast forward, came WHI. Before WHI, we thought that just giving women birth control pills if you were in Europe through menopause, they'd be okay. If you were in the United States, you had to stop giving birth control pills when they were 35. Not that anybody explained why or how. I had no idea, but I did it. And then the Women's Health Initiative came. The interesting thing is that right before the Women's Health Initiative came, I had turned into a doctor who was taking care of women. And I was doing prevention and I was doing hormones. They were called natural hormones in those days. So there was a woman who was doing an article in Vogue magazine, of all people, about me. I have no idea why. And it was about the hormones that we were using. And she called me and she said, you know, that the study that, you know, you guys are, that the government is conducting is going bust. What do you think about it? And I thought, I don't know. Yet again, I didn't know. Well, the Women's Health Initiative is the moment in time when women's health took a turn for the worse, if that was possible. I didn't think it was. Now, fast forward 9 years after Women's Health Initiative, and I don't want to bore you because you all know about the Women's Health Initiative. You all know the Women's Health Initiative came out with the study had to be stopped early. The women got breast cancer. They had Alzheimer's, they had all kinds of problems, and it was all because of the hormones that they were receiving, which turns out to not be true. But in any case, it was good enough for the media to jump on it. And then it was also good enough for us to not prescribe hormones. And the American College of Obstetrics and Gynecology and the North American Menopause Society got all together and they all started saying to physicians, you cannot prescribe hormones. We're not taking responsibility. Everybody ran for the hills. IMS, for those of you who don't know, is the International Menopause Society. So in 2011, so this is like 9 years after the Women's Health Initiative, I have been writing for bioidentical hormones, which were the natural hormones in those days, now since 1996, so almost 10 years. 9 years after the Women's Health Initiative, the International Menopause Society had its annual Congress in Rome. So I went to the Congress because I figured they might be more open-minded and they might give us more information. Now, the interesting thing that came out of that I came home with was that there was solid data on the increase in cardiovascular disease risk in women with high frequency of hot flashes. And that was published in Menopause in 2011. And it was also backed up by other studies in Israel and other places. And then the most important thing was that there was unequivocal data demonstrating no class effect for hormones. So what I mean by that is that all estrogens are not the same. All progestogens are not the same. So when you're giving somebody Premarin, like they were in Women's Health Initiative, you are not getting the same effect as you would if you're giving somebody estradiol, which is the bioidentical hormone. The same thing with progestogen. If you're giving them norepinephrine, you're not going to get the same results as you will get from progesterone. However, and still, with this amazing information in my hand, and now having practiced 10 years of giving women bioidentical hormones, I come home and somehow this information never crosses the Atlantic. To this day, I still have patients who come to me and they trust me. I've been doing this for long enough, and they believe in what I say, and they still come and say, my gynecologist said, I can't take hormones. Hormones will give me cancer. I don't know where that came from, but it's not the truth. And then, where are we 10 years after the Women's Health Initiative? Rogerio Lobo, who used to be the chairman of OBGYN at Columbia Presbyterian, was the one who started in 2013 this whole series of articles that were by the principal investigators of the Women's Health Initiative that were published in Endocrinology, Metabolism, British Medical Journal, Annals, everywhere, that told the story of how the Women's Health Initiative was a flawed study. The women were too old. They were more than 10 years past menopause. The data was not true, that all-cause mortality was decreased in women who were on hormones, and basically blew up the whole Women's Health Initiative. But oddly, and this is about women's health, and I'll get to a much broader women's health perspective, that alone did nothing. The media never picked up those news. And the North American Medical Society, as well as the American College of Obstetrics and Gynecology, never told their doctors. It's not like we don't know that gender-specific medicine is the study of how diseases differ between men and women in terms of prevention, clinical science, therapeutic approaches, prognosis, psychological and social impact. It is a neglected dimension of medicine. And this is from 2013. If you remember, I showed you a slide before from 1992, 94. What changed? Nothing. This is 2013. Nothing's changed. Where are we today? And this is from January 22nd, 2023, last week, an article in the New York Times. It's called "Most Abortion Bans Include Exceptions. In Practice, Few Are Granted. Mixing politics with patient care will never help improve the status of healthcare. Doctors don't practice healing arts. They're scared of losing their license. Administration and insurance companies determine what our medical care is like in 2023. This article basically shows us how, rather than doing what the doctor thinks is right in the case of a patient who needs an abortion because there is some really deadly situation in place, the doctor has to go to the administration of the hospital and ask permission. And if the doctor doesn't get the permission because the lawyers say no or whatever happens, that patient is lost. And that patient is a woman. It's abominable. So where does the confusion come from besides cultural? Let's talk for a minute about public health versus individualized health. When we're talking about public health, we're talking about data that is collected and that academic institutions, government agencies collect to figure out what populations will do under different circumstances, what will help large populations. But when you're talking about individualized health, we are told that we're talking about people who can afford healthcare individually. But that's not what individualized healthcare is. Individualized healthcare is you and me. When you sit in that office, in that examining room with the patient alone, that's individualized healthcare. The public health information, the research, the studies, anything that you bring to the table that you've learned, that you've read, that you've been told that exists about a particular disease entity or anything to do with that patient's particular situation or condition, now has to be kind of gone through through a sieve and just like become individualized to apply to the individual patient. So anyone who's sitting in front of you is individualized health. So let's look at the public health, right? The World Health Organization in 1995, there were 20 countries that signed pledges in Beijing, a declaration of action, including what they signed for is to improve women's health. The women's right to health access and equity is an issue in developing countries with lopsided gender justice, which makes me laugh because not much difference, according to the World Health Organization, really exists between developed and developing countries. Look at where we stand in the United States. And we spend more money than anybody else on healthcare, but not on women's health. Government and public health systems haven't raised awareness and haven't addressed women's health needs. Actually, there was a blog that was in the A4M Medicine Redefined about menopause that actually came out last week. And they're talking about the fact that the amount of money that is spent on women's health is 1%. And we are more than half the number of people in the country. Obscene. Now, take a moment and look at this, because this becomes really important as we move on. According to the World Health Organization, the top 10 killers of women that should be addressed, and I'm not saying they shouldn't be addressed, but let's look at them, are heart disease, which are in women undetected and underdiagnosed. Why? Because women don't have the same symptoms. We know women, have tooth pains, they have back pains, they have shoulder pains, but they don't have the same symptoms as men. I remember going to the funeral of a woman who used to be a nurse that worked with me at one of the hospitals years ago. And she was in her 50s. She had just gone through menopause and she died of heart disease. She had a heart attack. She had gone to the emergency room 5 times and she was not diagnosed. In those days, they weren't doing troponins and they weren't doing CAT scans on everybody, but the EKG was non-conclusive. So she died of heart problem. Cancer is the leading killer of women globally. Well, before we take that as the gospel, I'd like to remind you something that I've lived through, which is 20 years ago, DCIS was not considered cancer because it doesn't really spread. It was added to the list of cancers. So in order to maybe create more cancer diagnoses and more positive results, because it's very easily taken care of, and to increase the number of women who will get their annual mammograms or maybe every 6 months mammograms. But cancer is the leading killer of women globally. Gynecological health issues, which means pretty much anything. Osteoporosis, osteoarthritis, psychiatric disorders, diabetes. The reason I put that article down there from 2006 is because it's from Marianne Legato, who is probably the most gender-specific, trying to get women's health on the forefront where it belongs, actually. And she was trying to talk about women with diabetes, women with heart disease, and how do we treat them? She works at Columbia and she has the women's health department over there. Endocrine disorders, anemia, stroke. I think that all of these 10 don't look foreign to you, right? But what are the reasons why things are getting worse? How about the siloing of healthcare? What did I just show you? I showed you how we can silo everything, right? These are silos. We can also silo the age of the patient, right? We can also bring in the subspecialties. In the 1970s, we brought in subspecialties. Nobody went into primary care anymore because they made more money in subspecialties. All the advances and all the money for research went to the subspecialties. Hasn't changed much today. A lot of great stuff has happened because subspecialties are amazing. They, DNA is really, the DNA mapping and CRISPR is not really the end all be all, but look at the fact that we're replacing hips, we're replacing knees, we're doing all kinds of really great stuff with subspecialties, but they're doing it in a vacuum. They're not helping the whole woman. They're only helping the particular area of the woman. So you can go back to those 10 things there. The lack of new information sharing. And we talk about this all the time. And in our podcast, Redefining Medicine, we talk about it because a lot of researchers come and share their information with us, and the information is amazing. And I think I am so blessed because I hear it firsthand. How much time does it take for new information to go from the lab to the application in the clinical practice? And you know what the answer is? We don't know, but it varies from 5 years to 25 years. How would you like to be a patient that you're being seen by a doctor who doesn't have access to the medical education that you need, the new information? Medical education is stagnant. I was president of the board of alumni at Downstate, and I was the only woman at the table, and the rest of them were the same guys that taught me 20 years before. The problem is that things don't change. It takes forever to move forward. But we're moving forward. We're moving forward with so many things. Women are now running companies. They're in the boardroom. They're showing how important we are to the growth of the country, the evolution. Not only are we raising the children, we're raising the country. We're raising the world. But the medical education is still run by the same people who were running it 50 years ago. Research is stagnant. We don't encourage anybody who's going to think differently, unless you're at A4M, which you are, which is wonderful, because that's where you actually can start talking about things that are different and how you want to improve things and change them. The resistance to change at all levels of the system is appalling. Does anyone actually care about women? You know, I was talking to somebody today about being a doctor and how becoming a doctor as a woman, now that half the women in the medical, half the doctors that come out of medical schools are women, you think, well, this is wonderful. Well, it's wonderful if you think that women will bring what makes us women to the table. It's not wonderful when they become men. They take on the attitude, the behavior, and the thinking of men in order to fit in. It's time to stop the fitting in. So the gender and the socioeconomic health disparities are huge, but what are they? The mortality, women live longer than men. Well, what's that going to do? You're just going to stay there, retired, and without hormones, feeling horrible and not being able to contribute, right? Life expectancy. Yeah, it's gone up, but it hasn't gone up significantly anymore. And after COVID, and we've learned from COVID, it's come down. The burden of disease is huge. And as we get older, it gets larger. So focus should be on prevention rather than on the burden of disease, right? What about mental health? What about the fact that women carry all the problems of the family, all the problems of the world? The mental health issue is huge. Where do you go? You go to the psychiatrist who spends 5 minutes with you and gives you a drug, or you go to a therapist that most women that I speak to don't connect with them. So you need to change that. Now, the uninsured versus the underinsured. Remember, we're talking about still on the public health part of it, what the issues are. Why are there such disparities? Well, as of 2021, the Robert Wood Johnson, the Urban Institute, the interaction with healthcare providers is poor because people, and that's not just women, it's also men at this point, avoid interaction with healthcare providers if they expect to experience discrimination and racial or gender bias, which is beyond sad. Women are at higher disadvantage than men. Of course they are. These disparities are not going to go away by themselves. You're missing huge pieces in order to get anywhere. So here are the conventional solutions. Remember, we're talking about the World Health Organization, the treatment of women in the public health domain. We'll get to where we are. The conventional solutions would be to expand insurance to cover healthcare costs. What healthcare costs are we covering? End of life? Disease? Because that's what we're talking about. Is it worth expanding, spending more money to cover something that has never helped anybody? I remember when I was a resident that no one died on your shift. That was the rule. Well, today, I think kinder medicine would work a lot better than nobody dies on your shift mentality. Expanding telehealth services, which we were practicing telehealth medicine about 20 years ago when we started doing hormones, right? But the interesting thing is we went to the New York State Attorney General's office and we were told that there was no precedent. We told them that it didn't matter. We didn't really need to examine the patient. We didn't have to see them face to face. So we were given permission to do telemedicine, which at the time was basically telephone medicine. So COVID helped us because telehealth was really the only way you could get any kind of healthcare. So expanding and extending telehealth services, especially in rural areas, and giving access to women who don't have babysitters, who are not able to get away from home to fit the doctor's time, office hours, can actually have access. Invest in mobile clinics. I totally think that's a great idea. Rural medicine, rural healthcare. But what are you going to do in these mobile clinics? Are you going to do pap smears, mammograms, and clean their teeth? Or are you going to talk to them about prevention? Are you going to address how to prevent disease? Are you going to help them enjoy a better, healthier life? And that's up to us at this point to push this. We have to educate the public on the availability of where you can find the right care. We have to improve the cultural responsiveness because women are getting the bad healthcare they're getting because of cultural mores. As I said, we've made it more into the professions. We've made it more into the boardroom. But unless our health is hand in hand with a cultural approach to what women can do and will do, we're not going to be able to be healthy enough to make the difference that we need to make. So we need to train people in the cultural competency. Now, I'm going to take one more sidebar because I will finish in 15 minutes. And that's what is academic medicine and women's health doing? And the reason I did public health and now I'm doing academic medicine is because we have to understand why we are where we are and how we could change it. We have to integrate topics of sex and gender into medical curricula. And that's from one article from 2016 by Marianne Legato, again, who's the only person really who is pushing on educating doctors and providers on distinguishing between men and women and realizing that women have totally different needs. So innovations of medical curriculum, that's really a great idea. But this conversation, as you know, started in 1994. And to this day, there's very little innovation of medical curriculum. The challenge of definitions. If you read the blog I was referring to before, it was called Canceling Menopause. And I would really recommend you read it, the one from A4M Redefining Medicine. And I think it was from last week, actually January 27, so it was last week. I've been against definition. I'm calling it labeling. And I've been so angered and distraught by the idea of premenopause, perimenopause, postmenopause. Who cares? Menopause, just the name alone, is a definition by men that says that 1 year of no periods puts you in menopause. In my experience of 40 years now, I could tell you that that has nothing to do with what you need. What you need hormonally starts in your teens, in your 20s, and your 30s, and it changes. It changes according to the individual. So the challenge of definitions of labels, unequivocally, this is one way the conventional medical establishment has hidden from the public, by using labels and definitions that are so out there that nobody knows what to do with them. And I love this article, Canceling Menopause. I think we should cancel all those definitions that mean nothing. Overcoming unconscious bias so that the scientific evidence trumps political forces. I can't even address that because we just lost our reproductive rights. And I'm not making this a political talk. Emphasis on improved patient care. As much as I respect and I think the world of Marianne Legato, I think that the emphasis on improved patient care does not come from 2016. It comes from the beginning of time, from the first doctor. It is about patient care is the only thing that makes us doctors. We're there to heal. We're there to care. Now we're going to start emphasizing it. We have to. Without it, we're done. The integration of sex and gender into the medical education will lead to improved medical care for all. Excuse me if I laugh. So what are the global initiatives that she was referring to in the article? Interestingly enough, there are a few places you can go where women's health is not just about pap smears and mammogram. We actually sit with the doctors and the providers, and you go through your life and your issues in your life that upset you, that you might want to get some support with. One of them is in Berlin. The other one is at the Karolinska Institute in Sweden. The other one is in Canada, in Toronto. The Texas Tech University has one, and Columbia University is where Marianne Legato is. Those are promising. Those are where everybody should be. But how do we get there? So let's go back to mental health, because now I want to talk about what really is, where we are. Women go through different stages and phases, right? Whether you're a teenager and you just got your period and you're not thinking straight and you're worried about the pimples on your face and having to miss a day of school because of cramps, and you start worrying about boys, that's hormones. And then you go on. Then you get pregnant, you have babies. Then you become a mother. At the same time, in order not to miss out on the fact that now you have the opportunity to be a participant in society, you have to be a mother and you have to be at work. Women are caregivers at all ages. One of the doctors who works with us, Dr. McKiddish, is the oldest of 9 children. She is amazing. She cares. But you know what? I bet she's been the caregiver of those 8 little kids that followed her from the time she was a kid. Women are caregivers. We like it. We should be encouraged to do it, but we need the support to do it well. The change in hormones, birth control pills, and antidepressants. And today I saw a 25-year-old who had a Mirena IUD placed, and Mirena has hormones in it, and she had horrible symptoms. Nobody told her that she would start gaining weight, that she would have recurrent urinary tract infections, that she would start getting bloated, and that she would have abdominal pain. But the problem is that who would tell her that? When I told her, she was like, well, why do I have that in me? I said, well, because you knew enough not to ask for birth control pills, but now we have to put in a different kind of IUD. But how many women wind up going to 10 different specialists instead of knowing that these are not helpful? And antidepressants for PMS Seriously, you think about it. 1 week of antidepressants is going to help us with PMS. I can tell you that I have thousands of patients who do really well with their PMS with progesterone. No one asks, unless seeing a psychiatrist, mental health is nowhere. You're not getting any help. And I don't know that psychiatrists are the ones that help you because they're prescribing antidepressants. They don't know any better. So how do you get access to mental health care? Well, I told you before, it's pretty questionable. You have to be able to find somebody who's in your insurance plan or pay outside the plan, and then be able to find somebody who you click with, who can help you. Women are afraid of stigma in general. It's sad to say that in 2023, but it is the truth. So let's get to reproductive health, which in 2007, I was speaking to the then chairman of the Department of OBGYN at Harvard, Dr. Isaac Schiff, who is now still the editor-in-chief of Menopause. And I said, we need a women's health specialty. And he said, what are you talking about, Erica? Women's health is OBGYN. I said, I beg to differ. I don't think so. I think that women's health is about women. Now, the only thing acknowledged as women's health in healthcare is OBGYN, right? But what happens after you have a baby? Between the time you had your baby, which, by the way, if you're lucky and you have insurance and you live in a place with good OBGYN care, you have a lot of weekly, monthly ultrasounds, bloods, everything, right? But then once the baby's delivered, what happens to you? You're gone. 6 weeks later, you go for your follow-up to the OB, and he says to you, he or she, because it doesn't matter, as I said to you, women who become doctors become men, really. They come to you and you go to the OBGYN, and what do they say to you? They say, well, everything looks good. Go home and have sex. What happened? How could anyone think that it's okay 6 weeks after you have a baby to go have sex? Who in their right mind, who doesn't care about women, would say something like this? What about the changes? You have a baby, you don't even know what to do with the baby. Do you have help with a baby? Is anybody helping you? The moment you left the hospital, you're on your own. The old extended family where the grandmother was there to help doesn't really exist anymore in our society. So we need help. That's where women's health has to come in. And then the next time you need the gynecologist is for your annual pap smears that even if you have normal pap smears for 3 years in a row, even the American College of Obstetrics and Gynecology doesn't say you should have one every year. But then the next time you see your gynecologist, if you're not having pap smears, is to have a hysterectomy, or there's a problem because you've been doing too many jumping jacks and you have also created a big problem in your pelvis because you've had all these babies, and then you need to have a hysterectomy. And if you don't need a hysterectomy, you're going to have a mesh put in to suspend, to keep your bladder and your uterus in. Well, those are really not women's health. Those are mechanical techniques necessary, maybe not. There is no postpartum healthcare for women, which is offensive. And in summary, there is no women's health. Aging, Women's Health and Aging Study was started in 1995. There's nothing in the literature of use since 2002. HRT is unavailable and is still a source of controversy and fear. It's not okay. Medical education is minimal. Older women are treated the same way as older men. They're siloed into whatever particular organ system is failing. GYN does not represent women's needs. And this is not, I'm not after GYN, I'm just to help women. If you go back to 1991, Jean Achtenberg wrote in a book that the current role of women and the state of the healing art is in a time of crisis in healthcare professions. It coincides with the reemergence of feminine values. Well, I think it applies to today. Today, we have to go back to female values. Feminine values will actually bring to us kindness, care, involvement in helping us achieve, involvement in trying to support each other. You know, our physician assistant, Jill, said to me today, how come women are watching TV, reality TV, where women beat each other up, and no one watches female sports? Isn't that interesting? Why don't we support women? Women need to support women. We have to reframe women's health as a multidisciplinary approach in research and practice. The role of reproduction, the possible repercussions of accepting the male experience as normative are terrible. We're living them. Forcing women to be considered in relation to the world they live in instead of them dictating. We have to challenge the old paradigm of women's healthcare as care of reproductive issues only. Women are not just here to make children. How can we get there? Well, we have to raise awareness in healthcare providers. Back to cultural competency. Our culture is a culture where women's health doesn't exist. Women don't matter. But women matter. We represent more than half the population. We are the ones who bring up the next generation. We need to increase health literacy. And I don't mean Google. I mean your own body. We have to know what's going on with us. Once we understand us, once we understand what's going on inside of us and what's helping us, then we can move on and the world can be a better place. We need more resources. We need to partner with organizations, and we have to track real results, not just public health results. So here's my call to action, because I have to finish in 3 minutes, because then I'd like some Q&As from you. We need a women's health specialty. I know I told you in 2007, I asked Dr. Isaac Schiff about it. He said that OBGYN's women's health, I don't think that there is such a thing. I think at A4M, and I'm not saying it because this is A4M and I love A4M because of what it stands for, but at A4M, we train and teach doctors, providers to look at women as a whole, to not silo them into buckets. We teach how women can get the best care and the best support from doctors who care, from doctors who start their conversation with the patient by saying, how are you feeling? What's going on with you? We have to treat women with respect. I think we've said that a million times. We have to stop perpetuating the culture of victimization and fear-mongering in healthcare. I wrote a book, it's called Don't Let Your Doctor Kill You. The truth is, it wasn't against doctors. It was actually helping doctors, be healers, help women, and help men too, because, women bring the men in, and men don't like to go to the doctor. They will only go to the doctor when everything's falling apart. So women are the first front line in healthcare and in everything, really. We have to train providers to focus on women and their health needs. We have to start education from high school. We have sex education in high school and middle school. Why don't we have women's health? Why don't we take the women and talk to them? I was the school doctor in Irvington School District many years ago. And I remember that they asked me to come in and talk at sex education. And I had all the girls there. And I said, listen, go home and get a mirror and take a look at your vagina, because the men will know what you look like better and faster than you know. You need to know. You need to know they're your parts. You can't be embarrassed. You can't be ashamed. There's the culture of shame and fear has to be eliminated. We have to teach women to take control of their own bodies and say no to inappropriate care. We cannot be victims anymore. Today, I was talking to my daughter and she told me about how her 8-year-old daughter went to the dentist, and the dentist is a wonderful dentist, but we always start with a wonderful part. The wonderful dentist actually pulled a loose tooth, even though it hurt her, and she didn't think she had a choice. And then my daughter, who's a brilliant businesswoman, said, you know, if I went to the dentist would say, let's say to me, you need root canal or something like this. I'd say, sure, anything you want. That's women. Why would we do that? Doctors don't know best. They don't live in your body. They have to treat you with respect. Otherwise, you don't need them. You're better off with no health care than bad, uncaring health care. We have to change the status quo. We have to stop letting men decide what women need. We have to provide educational venues to help women to learn more about themselves and their bodies. We have to develop incentives for improved women's health for both women and providers. This is nothing. This is just the tip of the iceberg. I see it every day. I care. I care about the women that I care for, and I care about the men that also are kind of getting the negatives because women are not getting the right kind of care. So this is the beginning. I hope this is helpful to you. I hope that this makes you think twice and that you help start a movement that we need women's health specialty. And A4M is really where the specialty, the nidus for the specialty, the nest where the specialty is starting. I've been practicing women's health now for a long time. And the doctor is an advocate for the woman. We're their quarterbacks. Let's all be their quarterbacks. Thank you so much for being part of this tonight. I so appreciate it.
Thanks, Dr. Schwartz. Excellent. I've got a lot of people commenting that they definitely agree with you, and a lot of amens.
Thank you.
In your passion and advocacy for women's health. This is, like the $64,000 question, which I know we've talked about in a lot of different areas in women's health or longevity medicine. I know it was something that it was a question you posed to Peter Diamandis, even in the podcast that you did with him. But I've got a question here as far as, how can we provide functional medicine care to those who truly need it, but are unable to afford it without insurance, right? And I mean, it's, again, similar. I know you posed that question to Dr. Diamandis when he was talking about some of the, the things that are on the horizon with regard to longevity medicine is making that affordable for people. And I think that's, continues to be the plight. We've got so many talented doctors that go through A4M education. But, it's kind of that rub of, they can do this. They've got cool care they can do, but it's not always covered by insurance.
I think that you're 100% correct. I think that if we do what we're saying, and we need to do it because we're looking at 1991, it's offensive that from 1991 to 2023, we're having the same conversation. I think that if the money, and I was actually reading this, if you put gold bullions at the door of the healthcare system, billions of dollars, it will never improve the healthcare system. So the healthcare system as is will never work. It's over. Now, if you put the money, though, into educating doctors and educating women, that's where the money needs to go. And I think when we were talking about those mobile clinics that they have and teaching women, giving them access, we can do so much online. And if we can't do it online, we should do it in the mobile units. There is a way. When we started doing hormones, and we had our own, the only natural hormone pharmacy, it was the only pharmacy in the country of its kind. And what we did is we did online. Women would fill out forms, and then we had 12 doctors, and we pulled the forms. We used to use Salesforce. We pulled the forms, we read the information because they gave us a lot of information of themselves, and we started them on hormones. And you know what? They did well. Everybody, most of those women would come back. We never gave anybody cancer. We never made anybody sick. What we did is we improved their sleep pattern. We improved their life. We made them able to cope with their lives better. So I think it's all about education and sharing information. You know, if you go online now and you see there are a lot of doctors, and I hope some of them are here tonight, that are talking about it. And they're saying, we can help, we can help. Well, the goal is not to make money. I think the goal is to make enough money that you can take care of yourself and your family, but the goal is to educate and improve the status quo, to change it, to change the way it is. Status quo does not work. And I think that once the education takes hold, and once women support each other and stop clawing at each other instead of supporting each other, I think what we will see is access becomes more and more available. And if you talk about Dr. Diamandis, one thing that he was saying, and I remember exactly the question, because he was like, he had no answer for that group. But the thing is, what Diamandis is saying really is that it's like a whole, and it's not just him, it's the people he works with, that the more availability, the less expensive. So the reason it's expensive, it's not really expensive now, but it's the more availability, the more education, the more people have access to it, the less expensive it becomes. And then the other thing is that insurance companies are paying, they say they pay for outcome, but they don't. They don't even know what hormones are. They don't even know what functional medicine is. They don't even know what prevention is. My stepdaughter is a lawyer in Florida, and she works for this large medical group that takes only Medicare and Medicaid and basically focuses on prevention. They teach people how to eat better. They teach people how to move. That's all they do. And the government's giving them money. So I think that it's doable. I'm sure it's doable. I see it here and there. I just think we need to eliminate the academic stance that they know better. They don't know better. They have no idea. They all have women's health centers that do pap smears and mammograms. And then they torture women by doing all kinds of unnecessary tests and unnecessary procedures. I think it's about education and about women not being victimized.
Would you say, though, over the years, though, because it's definitely a plight, right? It's like that uphill ball that you're trying to roll up the hill so that it rolls downstream, right? I mean, it's obviously over the years, you've been pushing that ball up the hill, right? I mean, it's been a slow roll for more acceptance, definitely on bioidenticals. I know I've got somebody here, and this is generally just a comment, on peptide therapy. We obviously understand, peptide therapy is very much where bioidentical hormone replacement was 20 years ago. Right. And we know at A4M, with the education that we provide, that it's, we're constantly watching the regulations. We know, it's always, it's kind of under threat from FDA. And plus it's, it's pricey, it's kind of that same similar thing that we just, I think all of us who are in this space have to continue that fight as much as possible. Exactly what you said, the education, You know, all of you who are on this webinar, you know, you're all in it, educating yourself, then you're able to transfer that education onto your patients. You know, and hopefully we can continue to keep making a difference.
We have to. It's not even hopefully. We have no choice. This is the problem. You know, I was watching on Gayle King, I guess, the morning show on ABC, a woman who's a friend of my daughter's who started a company that helps women, that helps with newborn children and, you know, taking the snot out of their nose and things like that. And she did very well. But she said, and here she is, she's not a doctor, she's not a provider, she's just a woman. And she says, no one takes care of women. No one cares. Once women delivered a baby, that's it. Well, we have to step in. This is a huge gap. And if we step into that gap and take care of women, we can change. We can make it a board certifiable specialty that's called women's health. And then we will shift. There will be a shift. Then there will be companies that will pay money to support our effort to get to rural America, to give hormones and, you know, supplements and education on, you know, breathing and meditation. It's not la la land. We've moved from there. That was yesterday's news. We know that's not true anymore.
True. So this is going to be my last question, and this is more of a clinical question, because again, I've got a lot of people definitely supporting, you know, what your message has been, you know, throughout this whole webinar this evening. But I do have one clinical question that came in, and knowing that you treat a lot of, you know, premenopausal, menopausal patients, is a little bit of, you know, what kind of typical protocol or advice do you give from a lifestyle and supplement standpoint, typically that kind of category of patient?
I think less is more. I think you have to learn from the patient. And I think, you know, when we say, you know, we spend an hour and a half with the patient, you can learn a lot about patients in 5 to 10 minutes. I mean, we spend an hour and a half because we have the latitude to do that. But I think that what you want to do is tell patients hormones will help you. If you start hormones early enough around menopause, and, you know, by menopause, I mean when your hormones change, not when you stop having a period for a year. It has nothing to do with anything. Hormones are really important. So I do give patients hormones, but I also talk about the fact that this is an opportunity. You're opening a new door. You now are not going to become an old, obsolete human being. You're going to feel good again. You're going to sleep again. You're going to feel good. Don't waste it. Exercise, do resistance training, start building your muscles. That's how you're going to stay young. Sleep. Make sure you get 7-8 hours of sleep every night religiously. Get off of alcohol. Stop drinking alcohol. It's toxic. It's killing us. Increase the amount of water you drink. Start eating vegetables, fruit, and increase the amount of protein, because protein is what keeps your brain and keeps your body, your muscles. So it's a whole picture. And then when you're talking about supplements, there's some basic supplements. And we know that because COVID taught us, because our patients, for some reason, did well because they were on the right supplements. They were on vitamin D, they were on omega-3s, they were on vitamin C, then they were on thyroid support, adrenal support. So they're basics that you start with. The other thing is, please, to everybody, don't overdo it. Today I saw this woman who came in and was taking 20 supplements. And these 20 supplements, which were given to her by a physician, these 20 supplements had the same redundancy, the same content, the same stuff in it. So the amount of stuff that she was getting was really obscene. And her bloods came back, and she had an elevated amylase, an elevated lipase, and an elevated ALT and AST. So she thought it was because she had just started Wegovy. I told her, I don't think it's from the Wegovy. I think it's from all the supplements. So be careful with supplements. Don't overdo it, and teach your patients not to overdo it. There are a lot of people who feel like more is better. Well, what I've learned over my years is less is more.
Okay, that's great. And then one particular person is asking whether you utilize any PAs in your practice or if you have over the years that you've practiced and how you use them.
Yeah, we have a PA. And right now we're considering another PA because what's happening is that our PA has developed her own practice. A lot of patients are coming and our practice is growing. So PAs are very important. We love PAs in our practice and we can't do without them. Very important. I think that as long as somebody cares, you're doing well. That's all you want, is somebody who cares and who's open-minded and is not afraid and is not there to make women feel like they're less than they are, because we're not. We're all the same.
I've got one more question here. When do you recommend, and hopefully I say this right, anastrozole? Is that right? Anastrozole. Yeah, thank you.
When they elevated DHT.
Women.
In women, when they have an elevated DHT, but we have a formula that is a hormone support formula that has diindomethane in it and endo-3-carbinol, and we're doing very well with vitamin C. So we really very rarely use anastrozole in women unless their DHT levels are elevated. But I want to tell you something else. You can find me very easily. You can tell them that, Amy, and I would be more than happy to talk to anyone. I think we need to get everybody together. We need to put together the movement of getting women's health as a specialty. So everybody who actually took the time to do this tonight, I'm so honored. And the reason I was crying at the beginning, I was so overwhelmed, was because I think it's so wonderful to live long enough to see that the time has come. We have to tell the truth and we have to change the way healthcare is done for women.
All right, I think that's good. I agree with you. So thank you for being with us tonight. Again, I know I've been messaging through chat to everyone who's on. We do have a couple women's health specialty classes coming up, one in February, February 16th through the 18th. Yeah. That Dr. Schwartz is part of the faculty there. Some other great faculty that typically teach for A4M, such as Tara Scott, Diane Ginsburg, Elise Gersh. Yeah, we have a great faculty lineup. This class is also repeated and offered again in March 23rd through the 25th. So those of you who are still on, and I know a few of you have dropped off, but I still chatted it. We are offering a special discount using the coupon code MasterClass500 to give you a $500 discount off that if you're interested in attending. We'd love to see you in Boca Raton, Florida. Both of those classes are offered in Boca Raton, Florida. So thanks again, Dr. Schwartz. And I know I'll be talking to you.
For sure. Thank you.
Thanks, everyone.
Thank you.
Bye-bye.
Bye.